Hi everyone. As you can see here in this first slide, Western Europe, just like most regions around the world, has an increasingly older population of people with HIV, experiencing an increasing number of comorbidities. A recent study on the Italian Icona cohort estimated that by 2035, 76% of people with HIV followed up in the clinical centers will be aged over 50, with 26% over the age of 65, and with 98% experiencing at least one comorbidity. And similar trends can be seen in many other Western European countries. Well, this is not just a demographic change, but something that will require a radical change in clinical approach and pose a challenge to the social welfare system. In general, there is an increasing awareness in Western European countries of the emerging needs of this older population, both from clinicians who in their everyday work are dealing more with the management of comorbidities and other health conditions than with HIV itself, and then older people living with HIV who are personally experiencing increased rates of multimorbidity, along with the additional burden of other health conditions, such as the one I mentioned in my previous presentation, and which are strongly impacting their quality of everyday life. Loneliness, social isolation, and depression are becoming part of the lives of many elderly people with HIV in Western Europe, probably like everywhere else around the world. When older people are no longer able to navigate the health system on their own and have no support from family and friends, they are often left alone and disconnected from their healthcare and from social support. There are ongoing discussions at all levels on how to adequately address these emerging needs. At community level, organizations such as the European AIDS Treatment Group have conducted campaigns and projects raising awareness on the topic. But in general, people living with HIV are lacking the necessary information on what aging with HIV could mean to them and what strategies to adopt to keep themselves in good health as they reach older age. At clinical level, health systems across Europe are very diverse from country to country. Healthcare is mostly free in Europe, guaranteeing access to essential services. But nevertheless, healthcare systems are not adequately structured to respond to the complexity of care for older people with HIV. What we see is a gap between European guidelines and everyday clinical practice, lack of staff, lack of resources, lack of time to dedicate to visits, difficulties in integrating mental health care and geriatric care in current healthcare settings, and finally, the lack of foresight and long-term vision of our decision and policy makers. At policy level in Western Europe, healthcare is mostly governed by the single countries forming part of the European Union. The European Union complements national health policies by supporting local governments to achieve common objectives. Therefore, advocacy is needed both at European and national level in pushing the agenda on HIV. But at the same time, there are examples of promising good practices where an integration of services and a person-centered geriatric approach have been implemented. But these examples are very limited in number and places. A few examples are a dedicated clinic to people with HIV aged over 50 at Chelsea and Westminster Hospital in London, established in 2009. A report reviewing 10 years of activity showed significant rates of non-HIV related comorbidities and polypharmacy, 46.6% and 69.3% respectively. This has led to the implementation of clinical care pathways and new joint HIV specialty clinics to improve prevention, diagnosis, and management of major comorbidities in people aging with HIV. Another example is the Modena Metabolic Clinic in Italy, established over 20 years ago, where Professor Guaraldi leads a multidisciplinary team that evaluates patients' anthropometric, immune, metabolic, and physical functions, as well as any cognitive impairment, combining clinical practice with educational interventions on lifestyle, for example, exercise and nutrition, with the aim of ensuring healthy aging in people with HIV. All people over 50 undergo a comprehensive geriatric assessment, which allows to evaluate problems related to age, frailty, vulnerability, and the risk of developing disabilities. the Metabolic Clinic is currently carrying out a study aimed at validating a virtual metabolic clinic to offer specific support services to infectious disease clinics in Italy. At policy level, initiatives such as the HIV Outcomes Initiative, of which I am a steering group member, are advocating to improve European health policies for HIV care, with a focus on health-related quality of life and on all those aspects which go beyond viral suppression. On World AIDS Day, at an event at the European Parliament, we presented what we believe are the four main key priorities in addressing adequate long-term care and ensuring good health-related quality of life for people with HIV. And two of these are directly address many of the things we are talking about here today: HIV and aging, and the prevention, treatment, and management of comorbidities and multimorbidity. HIV Outcomes has also strongly advocated with the European Commission for a study on the quality of life of people with HIV, which has been recently published. And finally, a note on European aging cohorts, which are pointing out the unmet medical needs of older people with HIV. But no studies are designed to detect best ART strategies in this population and the various outcomes which go beyond viral suppression. Frailty, geriatric syndromes, physical function, disability, quality of life, and healthy aging are still not routinely part of aging cohorts. Results from these cohorts with outcomes that go beyond viral suppression could pave the way to healthcare providers in addressing the unmet needs of older people with HIV. In conclusion, there's still a lot of work to do to ensure appropriate care for older people with HIV in Western Europe. Thank you.